Good morning. Welcome, everybody. We're going to get started. So, welcome to The Cell 2023. We're so thrilled to have you all here and to have so many people in person. I know many of you have come from across the continent to be here. This is an important milestone event for PSC Partners Canada. This is our first PSC Partners event that is fully sponsored and funded by generous grants and corporate sponsorship. And we are just so thrilled that everybody's here. We have an exciting full day planned, full of learning and support. I'd like to start by recognizing the generous sponsorship. So this event would not be possible without grants from University of Toronto, Medicine by Design, from the Chan Zuckerberg Initiative, and from the Canadian Institute of Health Research, and with support from our corporate sponsors, our gold level sponsor, Mirum Pharmaceuticals, and our silver level sponsor, Escient Pharmaceuticals. And I would like to get started by introducing our first speaker, Dr. Gideon Hirschfield. Dr. Hirschfield holds the inaugural Lily and Terry Horner Chair in Autoimmune Liver Disease at the University of Toronto. He is the director of the Autoimmune Liver Disease Program and the director of clinical practice at the Toronto Centre for Liver Disease, Francis Family Liver Clinic, and he specializes in primary biliary cholangitis, primary sclerosing cholangitis, autoimmune hepatitis, and transplant. But that is a very modest bio because Dr. Hirschfield is a key opinion leader and is very committed and a very compassionate clinician, and we are greatly appreciative of all he does to move research forward for those of us affected by PSC. So please welcome Dr. Hirschfield.
Wow. Do you want me, is it this one's turned off, is it? So I'm just going to use the microphone. So first of all, it's fantastic to see everyone here. And it's really, thanks to Mary, Jess, and everyone else. And it's really kind of you to take me all the way back to the United Kingdom and to get me to give you a talk in a sort of a Tudor-style National Trust property with, hanging chandeliers and emblems on the wall. So, I think today's obviously going to be super exciting for you, super interesting, and I can see what, the goal is to make sure that all people living with PSC and impacted patients, families, carers, not just understand the disease, but understand the efforts ongoing in the laboratory to learn more and ultimately to develop new treatments for the disease, which is clearly the priority. So we spend an awful lot of time, it's not just myself, Dr. Ghulam Hussain, and then colleagues across Ontario and beyond, looking after our patients with PSC. But clearly our vision is to move beyond what we do currently and to ensure that it's more effective treatments and ultimately cure. So the only thing you'll have to help me with is that I have a professional slide mover. So next slide. And we'll skip that. This is just to say that I'll work with any company that's prepared to develop new drugs for PSC. And so when they knock on our door, we always say yes, because we try very much to encourage them that this is a space that's worth investing their very, very hard-earned dollars in, because it's not easy developing drugs for PSC, and programs cost hundreds and hundreds of millions of dollars. So we're always keen to work with our sponsors. Next slide. So when you think about liver disease, clearly you're biased towards thinking about autoimmune liver diseases. But when we think about understanding liver diseases, it's really important to put it into context. And when we learn about inflammation and scarring in the liver, we actually put it into context of all the different causes of inflammation and scarring. And what we're trying to do is pick out things that are common and pick out things that are distinct for the diseases that we're interested in. The reason that's important is that if we are to get new therapies for PSC, and I'll talk to you in greater detail about what PSC is, then we might learn from the treatments that are being designed for viral hepatitis or the treatments that are being designed for metabolic liver disease, et cetera, et cetera. So we don't want to be siloed completely, even if we're obviously very much biased towards PSC, which is an autoimmune, autoinflammatory disease. Next slide. So in health, you want to have a healthy liver. It's smooth. The liver really is a very clever organ. We're particularly proud of it. Okay, it's particularly forgiving, and it's particularly smart. It's not just a filtration device like the kidney. It weathers the storm against injury, unlike the pancreas, which sort of falls to bits. The liver is really, really central to your health. It's central to your immune system. It's central to fighting infections. And it's a protein factory. It makes your clotting products or your blood to clot, and it stops you from being overwhelmed by infection continuously because it sits there and all of the bugs that come from the bowel are first passed through the liver. So in health, you have a nice, smooth liver. Next slide. But in sickness and over time, and this doesn't happen quickly, particularly in a PSC patient, the liver becomes scarred. And it's not hard to understand that if this is your liver over time, there is more scar tissue than there is functioning hepatocytes. Okay, hepatocytes are the engines, bile ducts are, the tubes that are basically producing bile and excreting it into the bowel. But if your hepatocytes and bile ducts are, stuck in the middle of the scar tissue, then clearly they can't function and they're crowded out. And that's when you're going to get to the complications, and that's when we ultimately, and you'll hear later on from Dr. Selzner, the importance of liver transplantation to solve this plumbing problem. Next slide. And, beyond the liver is equally important for our patients. Clinics are busy, we recognize that, but we try and find time to listen to you in clinic, to listen to the symptoms that come from beyond the liver. So, liver disease, jaundice, fever from infection, pain from infection, itch from bile ducts that are irritable and being damaged by the autoimmune system. But beyond that, we've got fatigue and brain fog, which we don't understand. We've got dryness, we've got other autoimmune diseases, we've got your bones to think about. There's inflammatory bowel disease. This PSC comes with inflammatory bowel disease in two-thirds of the time, in essence, statistically. Okay, there's treatment side effects. There's fertility, your mental health, and of course, all of that. On top of that is the worry about cancer. Okay, cancer is a reality for our patients living with PSC IBD. It's not possible to not talk about it, even if it's undesirable to think about it. But all of this then impacts how you live and feel with your disease, and that's why I think about the liver and beyond the liver. Next slide. And that's why whatever we do and whatever we develop and whatever we explain and whatever science we apply and whatever research we're interested in, it's got to be the whole patient, okay? Because ultimately that's the success. And that, of course, is also the challenge, is that we've got to work out what we can pick away at and what we can't pick away at. And we've got to make sure that anything that we do doesn't harm the rest of you. And the good news about PSC is that you live with it for a very, very long time. The challenge is, therefore, when do you choose to intervene with a therapy, okay, to make a difference? Because therapies may have pluses and they may have minuses, and so we don't want to give you the minuses until the minuses make sense. So this is a real challenge for PSCers. Next slide. So we did this slide. This is my always my take-home slide. We're very lucky to have a very talented medical resident who used to be a medical illustrator. Okay, so she was able to draw this for me. And we focused on the 6 C's of PSC, which I think help anchor your understanding of the disease. Okay, there are 5 that are medical, and there's 1 that was pronounced and chosen by the patients. I spoke to the PSC partners in Canada, the US, and in the UK as to what the 6th C should be, and the 6th C was cure. Okay, but we've got a disease that can be covert. Not many people may even know that you've got it. You may not even show it outwardly. The itch is not very easy to explain to people. The fatigue is not very easy to explain. So many of our patients are diagnosed long before there's any overt signs of liver disease. Then there are 2 fundamental, liver issues. The cholangitis, medium to large bile ducts. The bile ducts drain your bile. And the cholangitis is inflammatory and it causes blockages. So it causes scarring, and the bile can't leave the liver adequately. And there's lots of things behind the scenes that cause this. And that leads to cirrhosis, because the healthy liver does its very best to forgive the cholangitis over time, but ultimately the cholangitis wins and the scarring gets greater. Then the other two C's is the association, as I told you, with colitis. So a lot of our patients, not all of them, a lot of our patients will have inflammation in the colon, okay? And then unusually for autoimmune diseases, this is a disease which is predisposed to cancer, okay? Cancer of the colon, cancer of the bile ducts, and cancer of the gallbladder. We don't know why. We assume it's because those are organs, tissues living in the wrong environment over a long time, and some people, unfortunately, respond to injury by making cells that ultimately become cancerous. What the day is all about is cure, okay? So, of course, we would like to control, and that could have been our 6th C, okay? But really what we want is cure for our patients. And to do that, we're going to need new therapies. And our best therapies are going to come from the best science, which means understanding the disease, understanding the genes, understanding the bugs, understanding the environment, understanding how the cells talk to each other, how they communicate with each other. And already we learn from other diseases, so we work a lot on a disease called PBC, where our therapies have really taken off in the last 10 years to 15 years, and we think about what we can translate in. But additionally, we need to bring new ideas. And some of the stuff that you're going to hear, particularly from Sonia's group, is about hypothesis-free science, where instead of having the answer in your head because you thought that's the answer, you start off with a blank piece of paper and say, what does the technology tell me about this disease, and what does it tell me I should target? And we need some hypothesis-free science in PSC so we can not just look at what we know from other diseases, but also bring in some new science. Next slide. So, our patients want a new journey. This is a paper that I've been meaning to submit for about 5 years, but we will submit it in the next month or two, okay? And what we did was we interviewed in the UK. We sent one of my fellows to patients with PSC's homes. We didn't get them to come to us, we went to them, and they just spoke to each other. And they had a very helpful medical sociologist who then analyzed all of the discussions. It's really fascinating science, and somewhat more complicated, I hate to say it, Sonia, than just cells. But what you do is when you listen to patients, you hear the journey, and then you can actually hear all of the journey from about 20 to 30 patients gives you actually most of the stories that have people sort of resonate. Climbing the mountain before you get the diagnosis. Reaching the summit when you're finally told what's wrong with you, okay? Falling off the cliff when you then go to Dr. Google and you read about it, okay? And then soldiering on, living with PSC and adapting. And when I say falling off the cliff, of course, I apply that to the patient and the mother, okay? It's a big deal, okay? But actually, people do adapt. People are incredibly resilient, and people are really able to learn to, cope and soldier on. And then, of course, journey's end is what's going to happen to me as an individual. And for some of you, it will be, things will be relatively mild, and for others of you, there will be hiccups along the way, and, medicine and surgeons are going to be part of your journey. Next slide. And, our patients, that's why you're here today, can speak for themselves, and you can describe the important symptoms of pain, brain fog, cholangitis, fatigue, itch, weight loss, and can explain it in their own words. And actually, one of the most important things about today is this idea of patient participation and patient partnership in research. We're not asking you to be the leading molecular biologist or the person who understands bile acid science, but we're asking you to help us to frame our questions so that they're most applicable and most helpful, and we can prioritize what we do based on your input as to where to direct research dollars and research questions. Next slide. So when we look at autoimmune liver disease, our biggest challenge is we don't know the cause. So unlike our viral liver diseases, we know what causes viral hepatitis. You have either hepatitis B or hepatitis C or A, whatever, you name it. We know the virus, we know what it does, therefore we have the starting point. In autoimmune liver diseases, we don't have the starting point, and that's what then drives a lot of the uncertainty and a lot of the discussions, because you can't say it's due to one thing or other. And we look after 3 diseases, and you can see PSC's in the middle. PBC is the small bile duct disease, and we have lots of small bile bile duct. So this is a very, very slow progression, and it's very autoimmune. Autoimmune hepatitis is an inflammation against the liver cells, okay? And then in the middle is PSC, which is the disease we're really focusing on today, which is medium to large bile ducts that get scarred, and they get essentially fibrosis, concrete around them. And because there's evolving concrete around these bile ducts, the bile can't get out, and then ultimately the bile backs up, and then ultimately it gets infected, and that then ultimately leads to scarring. But our challenge is I can't tell you the beginning part. And without knowing the beginning part, that's why we struggle to really give the most effective cures. Next slide. And some people have described it in analogies, we like analogies in medicine, as cirrhosis of the bile ducts. Okay, so that's in essence is probably what's happening slowly. You've got the bile duct component of the disease, and then the liver, which is surrounding the bile ducts, is then furthermore damaged. And around this is a medium to large bile duct, and you can see that around it is just a lot of scar tissue. Okay, and this probably explains to you why some of the therapies we give you seem like a good idea, but have been very difficult to prove. So it's very unlikely that ursodeoxycholic acid, which improves your bile flow, is going to get rid of cirrhosis or concrete around your bile ducts. Okay? It might soothe it a bit, but it's unlikely it's going to be the most effective treatment for something as stark as this. Next slide. And then the lights are a little bit bright at the front, so you may not fully see this. Many of you would have had colonoscopies. The brave of you in the room might have been awake. I was completely asleep, so I didn't look at my colonoscopy. Okay, but some of you may have watched on the screen, okay, and seen the inflammation that the endoscopy doctor can see. And the inflammation is red and sore. We can actually now put cameras into your bile ducts. I don't do it. We send our patients to St. Mike's. Gary May and Jeff Moscow, who are amazing endoscopists, do this when we need it. This is what your bile duct looks like in PSC. So the first image I showed you was from the liver itself, sectioned. Okay, this is different. This is the tube, the telescope in the bile duct itself. Okay, it is not hard to see how inflamed and sore and ulcerated that looks. It is not hard to therefore see why you might feel the way you do, why you might have pain, why that might get infected, and why that might get inflamed, okay, why you're going to feel tired from all that inflammation, and why that over time could be the harbour of cancer. Okay, so that's what your bile duct looks like, and interestingly, it's actually also very, very similar to the appearances of your colitis at times. So there's a lot of similarities between the colon and the bile duct. Next slide. So when we evaluate you, what we do is we take your history, we choose the right tests, we identify whether your enzymes are more bile duct or more liver cell. So we call that cholestasis. Cholestasis is the damage of the biliary tree. Hepatitis is the damage to the hepatocytes. We then make sure we're not missed anything, so we take a full history. We want to make sure there's no other cause for the inflammation that we see on your blood tests. And that's when you then undergo an ultrasound, an MRI, a colonoscopy, and potentially, genetic testing and or liver biopsy, so that we can reach this diagnosis of PSC confidently, because I always say if you make a confident diagnosis at the beginning, then you know which path you're on, and then you're going to make sure you're in the right treatments, and you have access to, the right trials. Next slide. So we investigate you on blood tests, and again, the details really don't matter. These are just for me to anchor my thoughts, okay? We look at blood tests to see whether you've got PBC, and then we can say that your disease is a small bile duct disease, and you don't have PSC. But if you don't have those antibodies, we go looking further, and that's where the MRI comes in, and that's where the radiology report comes in, and that's where we're totally dependent on our radiologists to say, in fact, this is not small bile duct inflammation, this is large bile duct inflammation. And that's your journey as it begins. Now, I recognize that getting to that point can be slow, and many of you will have stories of how slow it was to get your diagnosis, or it felt slow, and that's clearly frustrating, and that's something we need to work on. Next slide. Everyone then asks us what's going to happen to me. And I just put this slide up now, but you're going to come back and hear some of the work from Dr. Batt's group and some of the machine learning and artificial intelligence. Clearly, We actually then use very simple things to help you guide what's going to happen to you. It's not particularly sophisticated. And we have a number of models that essentially look at your age, your blood tests, your liver biopsies, your spleen size, your platelet count. And we can use any of these models, they're all actually basically the same, to try and help you understand what's likely to happen tomorrow, what's in the next year, what's my 5 years look like, what's my 10 years look like, what's my 20 years look like. Because clearly you want to plan, you want to get on with life. Okay, so we use the information that we use to diagnose you to also what we call do prognosis. Next slide. And we want to use some of those technologies better. This is not an advert for a particular kind of MRI technology, but essentially what we've got on one side is what your bile ducts look like on a standard MRI scan, and then on the right-hand side, people are trying to develop better tools to say, well, if the disease is all in the bile ducts, why can't I use MRI to actually learn more about prognosis? You'll be surprised, but in fact, the best MRI technology for predicting prognosis at present is simply to measure the amount of liver fibrosis, nothing to do with the bile ducts. So yet the disease is a bile duct disease. So this is a company that's been working on using sort of technology to automate the MRI report and see whether you can quantify it. Okay, you can give some numbers to it rather than just an opinion. At present, your MRIs are opinions; they're not quantification. So this is something that we're keen, and we've got some studies with the Mayo, and with Perspectum, and with our own radiologist to work on this. Next slide. So, if we're going to get to that C of cure, we have to understand, what the diseases are caused by. I like this slide a lot because, Sheila Sherlock was a very famous hepatologist in the UK, and more than 50 years ago she was at it, and she's obviously passed away now. But she was, a champion of bile duct diseases at the Royal Free, and some of her work actually hasn't been changed. And some of the themes that you'll hear, are very similar today as to how she published this in the late 1960s. What's damaging your bile ducts? Is it chemicals? Is it abnormal bile salts? Is it infection? Is it the failure to develop the bile ducts correctly from when you were born? Is it the immune system? Is it some kind of malignancy? And some of those themes haven't really changed at all, actually, to this day. What we've done is try and piece together the story beneath each of those terms in much greater detail. Next slide. And what we now have is this concept, and these are the 4 autoimmune liver diseases: PBC, autoimmune hepatitis, PSC, and IgG4-related disease, with the disease incidence, which is the number of people who develop it per year, and the prevalence, the number of people who live with it at any one time, at the bottom. So showing you that these are rare diseases, okay? But behind the scenes, although there are similarities across these diseases, really the similarities on why people get them. Is it your genes? So yes, the genes are slightly different. There is something about the genetic makeup that predisposes to inflammation and autoimmunity. Is it something about how the cells behave when they're hurt? So yes, so cellular behavior changes by the environment that it is, and that's something called the epigenetic effects. The exposome is clearly very, very important to these diseases and very important to PSC. And by the exposome, what we mean is just everything around you, your life. Okay? Could it be smoking? I always remind people, PSCers don't smoke. Okay? Statistically, they don't. Okay? Whereas PBC patients have a high rate of smoking exposure. So there's a difference there, and I'll show you something about that later on. Socioeconomics, I'm going to show you. Drug exposure, industrial salt exposure, environments, vitamin D, etc. And then that dovetails into the microbiome. Whether that's cause or effect, we don't know. And it's all of these compartments that are contributing to the disease. Next slide. And what you've got is the Swiss cheese model, where things build up. Okay, different factors are at play, which ultimately lead to how you present with your disease. You've got your genetic susceptibility. These are not rare genes, these are common genes, so we've all got them, that predisposes to some, what we call autoreactivity, which means it predisposes to the tendency of your body to attack yourself. Okay? That means that the mucosa lining, so of your colon and your bile ducts, is abnormal, the inflammation is abnormal, and that leads to damage. And then the thing that we can't measure very well is response to injury. It turns out that, when we all get injured, some of us heal very well and some of us heal less well. And that's probably relevant as to why some people get mild disease and some people get severe disease. It may be they have the same journey at the beginning, but they have a different response to being sick and inflamed for decades. Next slide. And so the way I perceive this is that you've got essentially a bonfire, and bonfires catch fire. And when you make a bonfire, and I'd be terrible at making bonfires, I'm pretty much a city living kind of person, okay? So for anyone from North Bay, okay, who probably can make bonfires properly. But there are different kinds of thoughts if you think about genes and environment. So, you could have a bonfire that will simply just catch fire at, literally a damp match, and it will just catch fire. So that's the scenario where you've got some very, very strong genetic influence that basically you are going to get sick whatever happens. You simply, any tiny little match, and it's going to catch fire. Actually, what it's more like is on the right-hand side, which is what we think of as a low genetic risk of disease, which is essentially that to cut the bonfire to catch fire, you really got to douse it with a lot of petrol, and then it will catch fire. And so that's the complexity to identify. Next slide. The other things is around environment, and I thought I'd show you some of the work we're doing in Ontario. This is from Crystal Lung, where we've got all the data for patients with PSC across the province. It's all anonymized. We think they've got PSC based on coding. We find patients with inflammatory bowel disease, and then we code them for PSC, so completely anonymized. But, looks like a population of PSC. More men slightly, median age is 47, high rate of transplant. Next slide. But what we find, which is interesting, which is not to speak to you as an individual, but to speak to the environment that you find yourself in, is that there's a socioeconomic gradient. You do not see the socioeconomic gradient in inflammatory bowel disease. And by socioeconomic gradient, what I mean is that more of our patients with PSC-IBD have a higher income and experience less material deprivation. Okay? And now that doesn't work on individuals, of course. But what that says is that something about the environment our patients find themselves in, is it their diet, is it where they live, is it whether they're urban or rural, is contributing to why they've got PSC. And that also helps us to then think about the science we'd like to do in the future. Next slide. Genes, we would like to tell you there was a gene, but there isn't. This caused a lot of excitement in the PSC community. There was a family, essentially in Sweden, where they found a gene that caused PSC-IBD. But it's what we would call a phenocopy. It looks exactly like PSC-IBD, but when we then looked at sort of 3,000 or 4,000 other patients with PSC, none of them had the gene, unfortunately. Okay, so it helps us design experiments. We might give that information to someone like Sonia and say, this gene is really important. Can you model it? And can you work out why it causes the pathways that look like PSC-IBD, but it wasn't the answer as such. Next slide. Your colon is very important to us, and that probably is also very important to PSC in terms of why people get it. And your colitis tends to be slightly different. Not always, but tends to be. It tends to be slightly milder. We often have patients, and Amanda can talk about the fact in children, often very few symptoms from their colitis compared to the inflammation. So milder disease, more right-sided, a slightly higher rate of colon cancer. So it's slightly different. So that suggests different genes to classical colitis, genes which are more linked to PSC-IBD. Next slide. And this is, latest work just looking at genes in PSC, just showing you that, in fact, the genes for IBD and Crohn's and ulcerative colitis overlap a little bit with the genes for PSC, but not completely. It's not 100%. It's more like 50%. Next slide. And then what's really interesting is I want to highlight one of the things that we found from the genetic studies I found particularly interesting. It's not particular genes, but themes. I told you that PSC patients are non-smokers. So what was amazing in this study is they did some correlations between some traits, behaviors, which do in fact have some genetic influence, and having PSC and the genes for PSC. And there was a clear correlation with the genes for smoking behavior, which are the genes to not smoke, and getting PSC. So although it's an environmental trigger, or not smoking, it also alludes to pathways as to why that is actually real and why it's actually something about the biology. So there's something important there that we need to tease away. Next slide. And then, we have this complex interrelationship between the liver and the bowel. And again, the details honestly don't matter. But what's happening is that you've got a bidirectional communication between the liver and bile ducts and the colon and the bugs and the bile acids, and they're talking to each other. And they're talking forwards and backwards because bile acids go in a circle from the bowel back up to the liver. And what that means is that we've got to work out how that is abnormal in patients with PSC to understand what causes this chronic inflammation. Next slide. And we've looked a little bit at people's bowels, and this is not just my work, this is the work of many people. We started off back in 2017 with Nabil, actually. That is our work, Nabil Qureshi in Birmingham. And we just simply showed, along with others, that the bugs in your bowel is different if you've got PSC IBD compared to IBD compared to healthy. Just, they are different, okay? Not in a way that we can name one bug, but they just, when you put all of the signatures together, it looks different. And this is work that's ongoing to try and work out what that means for the disease and potentially for treatment, because maybe the treatments are in the bowel, not in the liver. We don't know. We'll need to find out. Next slide. The other thing is that, disease is very impactful, and we know that one of the features of PSC is that it affects children, okay? And it affects young people who then become young adults and over time. And one of the things we've learned, and this again, details don't matter too much, is that when a child presents with PSC, they often present very inflammatory, looking more like hepatitis. But by the time they come to my clinic and are in their 20s and 30s, their disease looks like pure PSC. So they start off, very hepatitis, and they change. And that's a response. I think it stopped working. Well, it's not working as well. Next slide. So our goal is to identify the compartments and to tackle those compartments. We have the liver compartment that we need to tackle, and you'll hear about that, and bile acids and bile transporters. We've got the immune compartment, which is the autoimmunity, autoinflammatory compartment. We've got the bile ducts themselves, which are caught in the middle, which are damaged and scarred, and then we've got the gut. And where we need to head is work out the relative contribution of those compartments at different times and how we can intervene to dampen down, abnormalities. Next slide. So in our vision, a PSC IBD program, which is, I hope, what we've been building. I've been back for 5 years this time, and we've got a lot more work ahead of us. But between myself and Dr. Guillermo saying we're pushing hard, and we now have 2 dedicated autoimmune fellows and a clinical associate doing a PhD. So we're trying to build the critical mass. We need to monitor our patients. We need to help with understanding. We need to help with quality of care. We need to help with research. Because living with PSC, there's physical illness, social isolation, and there's fear and uncertainty. Next slide. And so just to summarize, to end, my 5 points for PSC care is: 1, I ask my colleagues to diagnose PSC with compassion and carefully, and usually an MRI is sufficient with a history, with a colonoscopy to look for colitis, and we don't generally do biopsies because it doesn't help us make the diagnosis. It may help in research. I then have to explain risk and offer choices to our patients because I don't have all the answers. So patient choice is very important, okay? The use of URSO, how to use liver tests, how to use elastography, fibroscans. When do you want to transplant? Not too early and not too late. It may sound easy, but in fact it's one of the hardest decisions that we make on a daily basis. Manage symptoms in parallel to disease therapies. So we want you to feel well and to function, not just your blood tests. And we have an amazing array of drugs for pruritus now and in the future. Lots of companies developing drugs just for pruritus, which is very reassuring. Survey for cancer smartly, but honestly. We'll tell you we don't know what works and what doesn't work. And then, for the theme for the day, think trials. And I'll talk later on about trials. But if we've made so much difference in PBC, we can do the same in PSC, but we can only do that with evidence. And for drug development, that means clinical trials. That means someone has to be the placebo group. That means that you may have to have a liver biopsy, even if that's not part of your clinical care, because we're not just going to magically solve this problem. We can solve it by new science and new evidence. Last slide, thank you.
Thank you very much. We're going to hold questions until after our next speaker. I'd like to welcome Dr. Amanda Risciuto. Dr. Amanda Risciuto is a staff gastroenterologist at the Division of Gastrology and Hepatology and Nutrition at the Hospital for Sick Kids. Her areas of specialty include pediatric, inflammatory bowel disease, and IBD-associated liver disease, particularly PSC. She's also assistant professor in the Department of Pediatrics at the University of Toronto.
Okay, so good morning, everybody, and thank you very much for this invitation. So I had the great misfortune today of following Dr. Hirschfield, which is a very difficult task, but I'll do my best to entertain you and to inform you. So today we're going to focus, or in this next talk, we're going to focus on the gut component of PSC IBD. So as you've already heard, there's a very strong association between PSC and IBD, as reflected by the very simple fact that the vast majority of individuals with PSC also have IBD. And the exact rate of that differs depending on which study you look at, but in general, 60 to 80% of people with PSC are described as having concomitant IBD. When we looked at this at the cohort at Sick Kids, it was actually significantly higher than that. It was 90% of the children with PSC who also had IBD. So of course, this then begs the question, why does this coexistence between these two entities occur? And the short answer is we don't really know. So as you've already heard, there's a lot of unknowns when it comes to PSC, and this is one of them. But we do strongly believe that the gut-liver axis, that's the cross-communication between the liver and the gut that you've already heard about, the enterohepatic circulation of bile acids, we think that this is central to the pathogenesis of PSC. And a number of hypotheses have been put forward, but none of them have been fully borne out. But one of them is the leaky gut hypothesis. So this is the idea that if you have an inflamed gut in the setting of IBD, the gut becomes leaky and things get out of the gut that shouldn't. Bacteria or bacterial products, and they then travel via the portal venous circulation to the liver, where they can potentially incite an immune response and inflammation. In the past, there was also some work talking about aberrant homing of gut lymphocytes to the liver. So lymphocytes are immune cells, and there was work done showing that these lymphocytes were primed in the gut and traveling to the liver when they shouldn't, and this was thought to maybe be related to contributing to PSC. And so a very interesting question that arises, are PSC and IBD simply two diseases that happen to coexist in a single individual, or are they two manifestations of the same underlying process? And as you've already heard, there's a number of features to PSC IBD that are distinct, which leads me to believe, at least personally, that I think these are two manifestations of the same underlying process rather than just the coexistence of two separate diseases. But we don't fully understand the mechanisms at play. And this raises another interesting question. If that is the case, then why isn't it 100% of people with PSC who also have IBD? So a lot of unknowns that remain to be fully understood. So this is, Gideon stole my thunder here with this slide, and this is just to drive home that message that the appearance of the bile ducts in PSC can really look similar to what we see in the colon. So this idea of inflammation in the two places, again, contributing to this notion that maybe they're manifestations of the same underlying process. So as I've mentioned, there's more and more evidence emerging that the IBD that coexists with PSC is distinct from the IBD occurring without coexisting PSC. So one level on which we see that is genetics, and again, Dr. Hirschfield touched on this a little bit. So as you've heard, there are risk genes for both PSC and IBD. These are variants that are common and that each confer a small degree of risk for a disease. And although there is some overlap between the risk genes for PSC and IBD, they do not completely overlap. And at the bottom there, those are Manhattan plots that map out the genetic architecture of PSC, as well as ulcerative colitis and Crohn's disease in that top row, and then other autoimmune conditions below. And it's just to highlight that what you see in the PSC graph looks fairly different from what you see in the ulcerative colitis and Crohn's disease graphs. So in PSC, you see very strong associations, very strong HLA associations, which tends to resemble what you see in other prototypical autoimmune conditions like celiac, for example. So the genetics is one layer of evidence that the IBD with PSC is different from isolated IBD. The microbiome is also distinct, and we've heard this already. So if you look at that bottom figure, this is comparing the microbes found in people with PSC compared to individuals with IBD alone, and there are differences. There are some organisms that are decreased and some organisms that are increased. And definitely the IBD that coexists with PSC seems to have a distinct clinical phenotype. So firstly, If we think about the type of IBD that occurs with PSC and what it tends to resemble, if we wanted to fit it into a box of ulcerative colitis or Crohn's disease, it definitely tends to most often resemble ulcerative colitis. And what I mean by that is it's most often superficial, so not extending into the deep layers of the bowel, and it's typically continuous, meaning it starts in the distal colon, the left colon, and then proceeds in a continuous fashion over to the right colon. So those are characteristics that are associated with ulcerative colitis. But that being said, there's a number of features that are atypical for ulcerative colitis, and we've already heard about a few of them. So in conventional ulcerative colitis, there's usually this gradient where the inflammation tends to get worse as you move distally towards the rectum, towards the left colon. But in PSC IBD, there's this interesting phenomenon where we see exactly the opposite, and the inflammation is often worse in the right colon for reasons that we don't fully understand. We also more frequently see this thing called backwash ileitis. So backwash ileitis refers to seeing some inflammation in the last part of the small bowel, which is called the terminal ileum, in the setting of having inflammation in the colon next to it. So where the large bowel meets the small bowel, we see patients frequently have some inflammation in the last part of the small bowel. And although we do see that in ulcerative colitis as well, we see it more frequently in PSC IBD. And we also see rectal sparing more often. So rectal sparing is exactly what it sounds like, where the rectum is relatively spared and not as severely affected as the adjacent left colon. So again, this is kind of atypical for ulcerative colitis, but we tend to see it in PSC IBD. And then significant small bowel involvement is quite uncommon in PSC IBD, and certainly complications like stricturing, obstruction of the small bowel, or penetrating complications, which is where you can get a fistula through the wall of the small bowel and get an abscess or a collection of fluid in the belly. That's really uncommon in PSC IBD, and same for perianal fistulizing complications, also uncommon. And these are features that we see predominantly in Crohn's disease, and as I've mentioned, PSC IBD tends to resemble ulcerative colitis more so. So we don't often see those types of presentations in PSC IBD. And then this interesting question of label. What do we call the IBD in patients with PSC? I think we all have this tendency to want to fit it into a box, when we're writing our clinic notes. Is it ulcerative colitis? Is it Crohn's disease? There is this other entity called IBD unclassified, which is a bit of a grab bag, a label that we give to patients when they don't neatly fall into one category of ulcerative colitis or Crohn's disease. So, I think there is some merit to that, just to have a quick way to, understand in general what the IBD looks like. But really, I think that PSC IBD is its own distinct thing, and it probably deserves its own category. Next slide, please. So I just wanted to speak briefly to our experience at Sick Kids when we looked back to describe the IBD in our PSC cohort. And we did this in comparison to a control group of children who had colitis without associated liver disease. So this was going pretty far back to the year 2000. We had just about 75 children with PSC IBD who were compared to a control group of about 150 kids with colitis without PSC. In terms of timing of the PSC and IBD, the majority of patients presented with the two around the same time, 60%. The most common presentation is typically people come to attention because of diarrhea or blood in the stool or abdominal pain. And then as part of their workup, they get some blood work done, and it demonstrates elevated liver enzymes. That's probably the most common way that we come to uncover PSC. But then there were 20% of patients who presented with their PSC either before or after their IBD. And we also showed in our cohort that these features, the distinct clinical phenotype, was also seen in our group. The inflammation that was worse in the right colon, more frequent backwash ileitis, and rectal sparing. And we've more recently looked at the histology of the gut inflammation in the PSC IBD group compared to controls, and have found that there are differences there too in terms of the types of cells that are present. And I think Dr. Hirschfield alluded to this already, but we do tend to see milder IBD in the setting of PSC, whether we're talking about symptoms, labs, endoscopy, and it's both at the time of diagnosis and over time. Next slide, please. So this is a pie chart summarizing the time spent in different IBD disease states in the PSC IBD group on the left compared to the controls on the right. And the beige represents a state of quiescent IBD when patients were feeling well without symptoms. So you can see that the PSC IBD kids in general spent more of their time feeling well. And conversely, they spent less of their time with moderate to severely active disease. Next slide, please. And when we looked at medication use, the same message came through. The PSC-IBD group was less likely to receive steroids, more likely to never need to escalate to anything beyond 5-ASA. These are medications like Pentasa or Mesavant, and sort of our first line for treating colitis. And then by extension, they were less likely to need biologics. So the injection and infusion medications like infliximab, adalimumab, vedolizumab, and so on. Now, I will add the caveat that this is going back to the year 2000, and a lot of these biologics have emerged in more recent times, so the numbers are probably a bit different if we looked at a more recent cohort, but I think the general trends would persist. And then we looked at the rate of colectomy in the two groups, and in pediatrics, when we do a colectomy for colitis, it's for medically refractory disease, as opposed to in adults where some of their colectomies are for colorectal cancer. We fortunately very rarely see that in the pediatric age group, so this is really reflective of colectomies done for medically refractory disease, and it was very uncommon in the PSC-IBD group. Only 1 of 74 patients proceeded to needing a colectomy because their disease didn't come under control with medical therapy. And so if you look at these numbers, these are ratios that represent the risk of proceeding to colectomy. So the fact that the number is less than 1 there means that the risk in the PSC-IBD group was significantly less. In terms of how we treat the IBD in PSC-IBD patients, really it's the same principles as when we're treating conventional IBD. The therapies seem to have the same general effectiveness, so there aren't really any big differences. I did want to briefly mention that at the time that vedolizumab or Entyvio kind of came around, there was a lot of excitement around whether it might actually be beneficial for treating the liver component of PSC-IBD. And this is because its mechanism of action is to block lymphocyte trafficking, so blocking the movement of lymphocytes out of the gut. And as I've mentioned, one of the hypotheses of PSC pathogenesis relates to aberrant homing of lymphocytes. So there was a lot of excitement around this, but in the studies that have been done, it hasn't really been borne out. It hasn't proved to be, a miracle drug for PSC. But that being said, it seems to work well for the IBD in PSC patients, and it's a very nice, safe medication that we use quite a lot. So I've mentioned that the IBD seems to be milder in this population, but there's an important caveat to that, which is that symptoms in this group don't seem to very accurately reflect what's happening inside at an endoscopic level. So when we took a cohort of kids who were in clinical remission, so in other words, had no symptoms from their IBD, we found that those kids with PSC were more than 2 times more likely to have active endoscopic disease, even if they were feeling well. So they have a higher rate of sort of silent or subclinical gut inflammation. So this really highlights the importance of objective monitoring, so using things like stool biomarkers of inflammation, like fecal calprotectin, which is something that we do a lot of. So we're always pestering people to bring in stool samples, and also the importance of regular endoscopy. And you've already heard that there's a heightened risk of colorectal cancer in PSC-IBD, and certainly this low-grade sort of grumbling gut inflammation is an important risk factor towards that. So it's very important to firstly demonstrate it and treat it. So as you've heard, the risk of colorectal dysplasia and cancer is increased in PSC-IBD. We know that there's already an increased risk of colon cancer in conventional colitis or isolated colitis, but it's even higher in patients with PSC and colitis. There are some other differences. So the colon cancers in PSC-IBD patients tend to be diagnosed at a younger age. They're more often located in the right colon, which goes along with the fact that the inflammation is more often in the right colon. And in addition, they can be really tricky to pick up. So they can have an atypical appearance, just subtle, flat abnormalities in the colon, or sometimes they can even be invisible to the eye and they're just picked up on random biopsies. And importantly, the risk of colon cancer persists even after liver transplant. So screening colonoscopy is, of course, very important, and it's recommended annually from the time of diagnosis of PSC-IBD in adults and in postpubertal children. Guidance around frequency of screening colonoscopy in children younger than that is unclear. There's really no good data to guide practice. In general, for younger patients who've had the disease for a long time, so 8 years plus, we feel that at that point, starting to perform annual screening colonoscopy makes sense. But in the younger kids who've had disease for a relatively short duration, there's really no good guidance as to frequency, but we think, every few years probably makes sense. And there's also it's also not entirely clear what the best method for screening colonoscopy is. There are different devices and different methods that can be used to screen for colon cancer during the colonoscopy itself. Some people do what we call random biopsies, which is where you take a number of biopsies every few centimeters in the colon. And there's definitely lots of variation in practice between different gastroenterologists and no clear evidence to guide which is the best practice, but certainly the important thing really is to make sure to get a screening colonoscopy every year. And then I just wanted to finish by talking a little bit about the relationship between IBD activity and PSC. I think this is a very, very important and interesting topic where there's a lot that remains to be learned. So the question arises, does IBD control influence PSC progression? Next slide, please. And I think the short answer is that the data are lacking and a bit contradictory right now regarding the influence of IBD activity on PSC progression in patients with already established disease. So thus far, there's not really clear-cut evidence to that effect. But that being said, I think it's important to keep in mind that it's a very hard question to study and to answer. You have to somehow quantify IBD activity over time and try to tease out its influence on PSC progression, somehow accounting for differences in PSC severity at time of presentation, because of course some people present with milder disease, some patients present with more severe disease. So I think it's just that we haven't done the right study yet. And I think intuitively we all feel that treating the gut to mucosal healing is very important in the setting of PSC IBD, and we need more literature to clearly demonstrate the benefits of that. Where there's been clearer evidence is looking at the role of the gut for preventing PSC recurrence after transplant. So there are a number of studies that have suggested that performing a colectomy prior to transplant helps to prevent the risk of PSC recurrence after transplant. So this seems to clearly suggest that there's something going on in terms of the communication between the gut and the liver, or the influence of the gut on the liver in terms of triggering PSC. So on the right there, this is a meta-analysis where the authors of this paper summarized various studies looking at the effect of colectomy on PSC recurrence, and there was a protective effect. And then on the flip side, the presence of active IBD was a risk factor for PSC recurrence. There's also been one study using health administrative data that showed that a colectomy prior to PSC diagnosis, so colectomy before people even knew they had PSC, was associated with improved outcomes in terms of progression to liver transplant and death. And then there's been work done demonstrating that IBD severity is associated with the risk of colorectal cancer. So certainly the degree of inflammation in the bowel, its extent, and the duration of time that it's present, those are important drivers of the colorectal cancer risk. So that in and of itself is a very good reason to treat the bowel as best as we can. So in terms of my take-home messages, PSC and IBD frequently coexist. They may be two manifestations of the same underlying process, but we need to better understand what that underlying process is. The IBD with PSC seems to be its own distinct entity, genetically, clinically, microbially, and so on. And although it tends to be milder on average, subclinical gut inflammation, or the presence of gut inflammation in the absence of symptoms, is relatively common. And so symptoms are not a reliable marker of what's happening inside, and we need to use other tools like biomarkers and endoscopy to really clearly document the degree of inflammation that's present. And while the influence of IBD activity on PSC progression has not clearly been demonstrated yet, we very firmly believe that it's very important to treat the bowel as best as we can, aiming for what we call mucosal healing, which means that when we do a colonoscopy, the bowel looks normal, and if possible, the biopsies look normal. So there's many reasons to continue to aim for that. Number one, it helps mitigate the risk of colorectal cancer. It's been very widely shown or repeatedly shown in the IBD literature that treating to mucosal healing is associated with better IBD outcomes, so a lower risk of relapse, a lower risk of progressing to needing surgery. And I think that there is definitely a possibility that treating the bowel to healing does potentially help to slow down the progression of PSC, but we sort of need the right study to be done to document that. And as I've mentioned, there's now a growing body of work suggesting that the presence of an inflamed colon is a risk factor for PSC recurrence after transplant. So that brings me to the end of that. Should I just go on? Yeah. So I wanted to just briefly introduce the Chan-Zuckerberg Initiative grant that this whole day is a part of. Next slide, please. So the study in question is entitled Deciphering the Cellular Ecosystem of PSC. So this was a call from the Chan-Zuckerberg Initiative for a patient-partnered collaboration focusing on single-cell analysis of rare inflammatory pediatric diseases. So PSC really fit the bill. And as you've heard a lot already, we strongly believe that the relationship and the communication between the liver and the gut is central to the pathogenesis of PSC, but we don't fully understand it, and it definitely needs to be better studied. And recently, there's really been an explosion in novel technologies that allow us to examine gene expression, not just in general within a tissue, but at an individual cell level. So we can actually see which genes are being expressed by different types of cells within a given tissue. So this led us to develop the study in question, which aims to map out the cellular immune landscape of not only the liver, but also the gut in PSC-IBD using these single-cell sequencing technologies. So I think some of the really novel pieces of this are the approach of studying both organs simultaneously. A lot of studies have kind of focused on one or the other, but rarely the two together, and leveraging these really powerful technologies to see what's happening at an individual cell level. And in the pediatric realm, we have the benefit of often seeing patients presenting with relatively early or mild disease before things become more muddied as they progress to more advanced disease. And we're also aiming to focus on patients who have not yet been exposed to treatment, because that too can sort of confuse the picture. So the goal is to help elucidate the key cells that are involved in driving PSC, both in the liver and the gut, and the underlying cellular mechanisms. And of course, the overall ultimate goal is to then use this information to help develop effective therapeutics. So that brings me to the end of the presentation. Thank you.
Thanks. Thank you. Thank you. Thank you very much, Dr. Risciuto. So we have 15 minutes for Q&A, and I'd like to welcome Steve Rossi to moderate the Q&A. Steve Rossi is a PharmD. He's the Chief Scientific Officer of PSC Partners Seeking a Cure. He recently joined PSC Partners to oversee the research program sponsored by the organization. Prior to PSC Partners, he worked in the biotech field for over 30 years, developing new medications for chronic liver diseases, including PSC. He received his doctorate at UCSF, and he has done postdoctoral work in transplant immunopharmacology. He's well known to PSC Partners and has been a volunteer for about 8 years. Hang on just a second. We're going to do a little bit of reorganizing here. So first of all, welcome to our online attendees. We're so glad that you're with us. We're going to try to do Q&A using Slido. So you can, and also from within the audience, if you have a smartphone, if you can take it out and go to slido.com and join the event at PSCP, you should be able to both enter questions that we'll be able to see on the screen and Steve can moderate, as well as be able to upvote questions that you're interested in hearing a response to. We're also going to have somebody walking around with a microphone if you want to ask a question in person. So we need to do a little bit of reorganizing of the microphones. So hang on. And Dr. Hirschfield and Rishuto, if you could come on up to the stage, please. So we're going to try to have you use this.
Test, test. A little louder. How's that? Can people hear me okay? It's still pretty low. 'Cause we're gonna... Test, test. There we go. Okay.
Is it on now?
There we go.
Okay.
All right. While we get Slido and other questions going, I'll ask one quick one for the two of you, and I'll ask you to compare the adult and the pediatric population, because I think there's some overlap, but then there's some very different perspectives. Gideon, you brought up ursodeoxycholic acid as a controversial but possible treatment, at least in the interim. For each of you, what are your decisions that make you decide whether to start urso in a patient? Gideon, you want to start first?
So I mean, urso is a drug that's really a bile acid that we all make ourselves. And normally your urso levels are around 5%, and you can enrich that by taking the tablet form of it. It originally came as a Chinese herbal remedy, and what that does is makes the bile acids less toxic. So inevitably, if you make the bile acids less toxic, they're hanging around, you can improve liver tests. The challenge has been that improving those liver tests has not seemingly made people necessarily live longer. There's some evidence that's made people feel a bit better for some patients. So I'm clearly of the opinion that it's not the panacea in PSC. I'm clearly of the opinion that it isn't a be-all and end-all, and it doesn't necessarily make people live longer. But because it can improve liver tests, and for some people, particularly patients who've got bile duct stones within their bile ducts, because it improves bile flow, it might help reduce the number of episodes of cholangitis. I am sanguine, and I will, quite happily, with the patient, agree to use urso for those reasons. And around 50% of our patients are on ursodeoxycholic acid. But I do tell my patients, if your insurance runs out, or there's issues about reimbursement, or the urso gives you side effects, some people don't like the thinning of the hair, some people don't like the GI side effects, that they don't need to lose sleep over it, because it's offering some help, but unfortunately it's not offering enough of the help that I'm looking for.
Okay. Go ahead, Amanda.
Yeah, so in the past, we used it pretty universally, I would say. In the cohort that I presented, 80 to 90% of people were on urso. I think more recently, given the evidence that Dr. Hirschfield has alluded to, demonstrating that there's no clear benefit in terms of hard endpoints, we've moved a little bit away from that. So our general approach at this time is usually to, after diagnosis, to take a few months to sort of observe the natural, what happens over time, because there is a lot of fluctuation just naturally in the liver enzymes with PSC. And so if we do see persistence of GGT over several months, we will usually try it. And if we see some improvement in the biochemistry, we tend to keep that on. We do definitely inform patients that this has not been associated with improved long-term outcomes, but I would say that's our general approach. And if we don't see a benefit, then we would usually withdraw it.
Okay, great. There was a couple questions about the relationship of colectomy, IBD severity, and the relationship to actually getting a transplant, and then recurrence afterwards. And one of the questions is, should colectomy actually be a standard procedure pre-transplant? And then in terms of actually looking at the overall how does colectomy in kids actually present in terms of those risk factors? So I'll let you both comment on that. Amanda, maybe start because you brought up the data.
Sure. I mean, I think it's a hugely important question. I'll add the caveat that the data that have shown a benefit, although it's a number of studies now, none of them are super high quality studies. They are all retrospective, which we consider to be a lower quality of evidence. That means that people kind of went back to charts or to administrative databases, which is not considered as rigorous as enrolling patients into a trial and following them over time, because the data you're relying on what's been collected. So the data that we have is not high quality. So personally, in terms of colectomy as a routine thing heading into transplant, I feel that the data are not quite there yet. Where we have had conversations around it in our population has been patients heading into a retransplant. Like in that setting, the prognosis is fairly poor, so definitely I think we should do everything we can to put the odds on our side. But we have not reached the point where we've started to consider colectomy routinely heading into transplant. Was that the whole question?
Yeah, I think the pieces of it. Gideon, how about in the adults?
So deeply personal for the patient, and therefore there isn't a perfect answer. And we have to distinguish between what we say at the population level and what we do at the individual level, because ultimately what the individual is what counts. So at the population level, active colitis post-transplant does associate with recurrent disease. Whether colectomy really helps stop that from happening, it's really unclear. There's some suggestion, but it's not, as Amanda says, it really isn't proven. So my approach is, first and foremost, is I encourage my gastroenterology colleagues not to soldier on too long. So if I see a patient struggling with their IBD, then I will be the voice of reason, and I will say, as any of you who are my patients, I'll be pretty clear what I think. Okay, even if the gastroenterologist doesn't necessarily listen to me, I'll say, you've just crossed the line. This is not helping you to keep trying the next latest drug. Okay, there's just a better solution, and a colectomy actually, for many patients, improves their quality of life significantly and is really very beneficial. It's very scary, but really makes a big difference. But there's a reluctance sometimes from the GI to lose. Yeah. So that's the first thing I'll say. We would never recommend a colectomy for everyone requiring a transplant. It's not logical, it's not necessarily safe, I couldn't tell you that it was going to change what was going to happen to you, because actually what happens post-transplant is as much determined by your genes and the liver genes as well as your bowel, so it's complex. To Amanda's point about patients who might need a second or a third transplant, then we're into sort of individualized care where we discuss with the patient. And then it's often the patient who brings it up, who says, well, although I know you can't tell me whether this is the right thing to do, I'd like to own some of this decision-making and some of this uncertainty. And if there's something that I can do, then that makes sense. The last point, sorry, Steve, to go on, is also, it's really tricky because a lot of our patients are young, okay? And that's great. And a colectomy often either involves a permanent bag or a pouch. And a pouch is fantastic as well, but it's more surgery, it's another operation. And patients with PSC probably get more complications of their pouch than patients without PSC. And a complicated pouch is equal to a very poor quality of life. Okay, so it's not, it's not a linear thing that says, X, Y, and Z. So that's why, we really have to individualize it to the patient.
Great. There's questions of the common or most popular ones have been floating up and down, but the microbiome is coming up in a variety of questions. And I guess, what can patients do to actually help their microbiome? There's a lot of focus on diet. Some people believe antibiotics, different types may actually influence it. You're looking at a variety of things that are being talked about as approaches. But what can patients do, and do you do anything to actually manage microbiome per se in your clinical setting? And does everybody understand what microbiome is? It's basically just the presence of different bacteria in your gut and different species of bacteria that may have different types of risks for progression of disease. Is that a good, simple way to put it? If you have any thoughts. Yeah.
Yeah, for sure. I mean, we get questions along these lines all the time in IBD clinic and in PSC IBD. I think this is another area where our understanding is not super sophisticated, where we're not at a point to say, eat A, B, and C and avoid D, E, and F, or take this antibiotic and you'll have a healthy microbiome. We don't fully, we know that the microbiome is different in PSC IBD, but we don't know if that's cause or effect, and we don't know which specific organisms are potentially causative. But in general, around diet, I give similar advice as I do to patients with IBD without PSC, which is kind of boring, but it's the principles that you would expect to aim for general healthy eating. We believe that there's something about the Western diet that has predisposed to the higher rate of IBD that we see in Canada, so we advise to avoid things like preservatives, additives, emulsifiers, things that are coming packaged. Lots of fruits and vegetables, trying to eat foods that are fresh, prepared at home. The general principles, like from the Mediterranean diet, generally are thought of to be anti-inflammatory. There are more specific diets that have been developed for Crohn's disease, for example, but they can be very, very restrictive. So in general, we advise these kinds of general principles, thinking that that's helpful. But again, data are sort of lacking. When it comes to antibiotics, of course, there's been a lot of interest in PSC IBD and a lot of interest particularly around vancomycin. It is not something that we routinely recommend. We don't have long-term studies showing improvement of long-term outcomes, and we don't have good safety data in the long term. We have used it on occasion on a case-by-case basis and through personalized decision making with patients who felt strongly about it or who had perhaps struggled with their IBD using other conventional medications. So those are some of the general.
There's a question related to that that's popped up. How about probiotics? And does that fit into your sort of microbiome thought, or just general health, possibly promoting mucosal healing? Where do probiotics fit into your mindset about treatment, or at least both for IBD and PSC?
Yeah, again, I think we don't have clear data demonstrating that probiotics are associated with benefit in PSC IBD. There has been some past work suggesting that certain probiotics might be helpful in ulcerative colitis. So certainly I don't think there's anything wrong with probiotics. So if someone was interested in doing that, I think that's fine. In principle, you could see how that could be thought of to be helpful, but there's not really good data to point to show that it's changed outcomes.
And I'll throw in there, probiotics, you have to be real careful because depending on the CPU, the amount of bugs in what you're taking, there's a variety of different responses, at least just in general health, and they're all over the board in
significantly immunosuppressed patients, there are some concerns as well.
A couple questions about the effect of, it says trauma, but I think stress, a variety of things. How does it impact, if at all, your thoughts on disease progression, activity of your IBD, and the relationship of the two? But I think it's mainly focused on how does it stimulate maybe the coexistence of the two diseases?
I mean, it's a bit like the discussion you just heard about microbiome and probiotics. It's all conceptually logical, and it's all conceptually easy to have the idea. It's just very hard to know, to prove, or what the intervention should be. So I don't think that chronic stress is good for you, and I don't think it's good for your immune system. Whether on an individual level that is deterministic, I don't know. But there's some fantastically interesting studies. There's a nerve in the body called the vagus nerve, and there's clear evidence that the vagus nerve is controlling your immune system, or it's not the only contributor to your immune system, but it clearly has a role. And so whatever you define as stress or trauma is therefore real. The challenge is, how do you intervene? And it's the same challenge as what is a healthy diet and what is the correct probiotic. It's all logical. It's easy to grab a headline. It's actually very difficult to then nail down what would be, the right thing for you as an individual, because we're all different and we all have different lives. And, PSC is only a component of your life. And you're going to, manage your life, and there's lots of things that you're managing, and you're not going to be in a position to not have to manage them, okay, whether you have PSC or don't have PSC. So I find it, quite difficult. So what I think we as physicians should be is just supportive, and if people want to use an adjunctive approach to their health, to me that makes a lot of sense. But if you choose not to, that's not to then criticize you. Because in fact, everyone's just doing their best. And, we're all just normal. And, and normal people, some days they eat too much and other days they don't. Okay, and we don't want people to then feel like, they've done something to contribute in a negative way, because that would be totally unfair and definitely untrue.
Yeah, great. There's something up here that's actually sort of, I think, broader, which is how do gastroenterologists and hepatologists work together? You guys obviously at the big institutions collaborate, but throughout Canada, how do the specialists actually kind of communicate both within the province, like in the community? How, Gideon, how do you interact with the community gastroenterologists, where frankly most of the patients are? You guys see the sicker patients or eventually get them, but how do you bring the knowledge you have out to the community?
It's good that our patients are mainly looked after in their communities, because they've got lives to get on with, and we're very happy to look after everyone with PSC. We've never ever turned down a referral. But at the end of the day, not everyone can get to Toronto easily, and web consultations are not the same as in person, so you have to have a healthy mix. My approach is that whenever anyone invites me to talk, I'll always go. Okay, and what we found is that the more we talk about it with our community colleagues wherever we go around the country, the more interested they are, and the more we help them just stay up to date and help them make decisions and help their patients through their own knowledge and continuing to be knowledgeable. And it is difficult in Canada. It's an enormous country. And, the gastroenterologist may only have a few patients with PSC, and that's correct because that's where they live. Or they may be in a big city where there's a choice to come to us, just because what difference does it make whether if you're in the GTA, does it matter whether you're stuck for half an hour on Eglinton or St. Clair? You might as well, you can, it's the same end point. So I think what we do is we just enthuse and we talk and we go to the conferences, CDDW, CASL. We go to what we call in the medical field the after dinner talks. And even if I'm talking about one disease, we usually end up talking about another, and we hope that encourages people. And fundamentally, one of the other reasons I do that is, and I'll admit to being fully biased, is so that when that community GI sees someone with PSC, they say, that PSC patient, they're special. They deserve more. Okay, maybe I should just get a second opinion, or I should just think about clinical trials, and I know who's doing them in my area. It's X, Y, or Z. I'll make the referral.
Amanda, I want to, because it's even more challenging for there's fewer pediatric gastrohepatologists with expertise. How do you make yourself even broadly available? Do you see patients outside the province? You're probably one of a handful in Canada that has that expertise.
Yeah, I think our model's a little bit different, even for run-of-the-mill IBD, where care tends to be more centralized to us. There are some community providers, especially recently, but definitely care is more centralized to sick kids. So I do think we see the vast majority of kids with PSC in the region. We're certainly happy to support our colleagues in the community with any questions. But I do think we see most of them, which, and in terms of collaboration between the gastroenterologist and the hepatologist, we try as much as possible to have a joint clinic where the hepatologist and the gastroenterologist is present to minimize the number of visits that patients have to come to, and conversations can happen jointly between all the relevant players. And it's also, I think, advantageous to have people centralized in one place if possible. Obviously, it's not always possible for research purposes.
So this is an interesting one, and I heard this at another forum. You've got a patient who is potentially heading towards transplant, has been listed, borderline MELD score to get them up the list. They're on urso or bezafibrate. Would you ever stop those medications to basically get their labs elevated to see if their MELD score would increase?
So the answer is gamesmanship or gameswomanship doesn't usually work or help.
Yep.
And so my practice generally is that, most of our patients get to transplant, and as those people live in Ontario, and it's probably slightly different in BC where they've got, in other parts of the province, we're very reliant on live donor transplantations. But most of our patients do get to transplant, which is great, and it's best that they get there as well as possible. And therefore, my general approach is to treat them as someone who's sick and give them what I think is best at the time. And so if medically I don't think a drug is helping them or might be harming them, then I'll stop it. But, trying to sort of artificially nudge the MELD score, won't materially change their position on the list. The list is complex, it's big, there's many different diseases, other patients who equally deserving, and plus or minus a point here or there is not going to be the answer. The answer is to be as healthy as possible, so when the phone call comes, either that you've got a live donor or it's your turn to have a deceased donor, is that you're well enough to not be sick on the day. So my general advice is not to meddle.
I think it's less of an issue, obviously, in the pediatrics. Most of the patients aren't on bezafibrate probably, and minimal or so, it sounds like. Or would you do anything different in the kids? No. Last question, because we're right on the edge. There's a general, and I think we need to narrow it a little bit. There's a question about mucosal healing. And obviously IBD treatment would be one of your primary approaches, but are there other things you can do to contribute to that? We brought up some of the things like diet, microbiome, anything else to promote actual healing from somebody who's more inflamed?
It's a good question. I mean, definitely the mainstay is our medical therapies. Yeah. And we use a treat to target approach. So it's not to say that every patient with PSC IBD needs to start on a biologic because, we really want to get to mucosal healing, but it's more about looking at the patient, risk stratifying them and choosing the therapy that's appropriate for their degree of disease. And in a lot of patients, they may just need 5-ASA to get there, but we of course need to reassess with an endoscopy and confirm where we're at, and if there's still ongoing disease, make a change and reassess. So that's the whole treat to target cycle, is you keep making changes and reassessing, and you keep going until you get to the goal. Fortunately, these days we have access to a significantly larger number of therapies than we did fairly recently, with the growing number of biologics and small molecules, so it's a very exciting time. We definitely do rely mostly on medical therapy because that's what's been shown in large trials to be effective. Otherwise, for sure, just sort of healthy lifestyle, healthy diet. I can't, again, point to a robust body of literature to say that that's going to get you to mucosal healing, but we think it's part of the overall picture. We do sometimes talk about natural products like turmeric that have been shown to have some anti-inflammatory properties. So if we're looking to add a little adjunct, we'll sometimes talk about that. But in general, we really are relying on our medical therapies to get there.
I'm going to, because I think we're to the end, so we'll kind of wrap it up. Thank you both for both your presentations and the great Q&A.
Thank you so much.